Hello everyone, I am José Moltó from Badalona, Spain, and in the next minutes I'm going to talk about clinical pharmacology conundrums. So within the last decades, there have been profound changes in the HIV healthcare model. While in the past our patients were usually young people, our patients are getting older. HIV infection was the main health problem in our patients, and main complications were age-defining conditions. However, currently HIV infection is just one medical condition, and our patients may have also different comorbidities and their complications. As a consequence, in the past, patient care was driven by one ID specialist, while nowadays our patients may visit different doctors for proper management of their conditions. And also, while current antiretroviral treatment is very simple with one pill regimen, it's common that our patients may take different drugs to manage their comorbidities, and polypharmacy has become the new rule. So in consequence of all this, while DDI management in the past relied mostly in one ID specialist, especially for current complex patients, this management of drug interactions may need of a multidisciplinary approach. This slide is to show how complex the situation can be. Our patients may visit different doctors, each of them prescribing drugs to manage their specific condition, and in this area of hyperconnectivity, many times without fluent communication among them. And this may have negative consequences for patient outcomes, as we will see in a few examples now. Starting with the first clinical case, it was a man who was diagnosed with HIV infection in 2003. He was starting on antiretroviral treatment with lopinavir, ritonavir plus FTC and TDF. He was doing fine. In 2005, due to increased lipids and decreased mineral density, treatment was changed to ralteravir plus 3TC and abacavir. But the patient reported some myalgia, and the doctor related this symptom to ralteravir, so he was put back on boosted protease inhibitors. In 2020, he was taking darunavir, cobicistat plus FTC and TAF. Viral load was suppressed and CD4 count was around 1100, and metabolic parameters were acceptable. However, the patient was admitted in the emergency room due to congestive heart failure and dilated myocardiopathy. He was referred to a cardiologist, and it was evidence anterior descending coronary artery stenosis, so he was diagnosed with ischemic myocardiopathy. A coronary stent was placed, and double antiaggregation was started with aspirin plus clopidogrel plus standard treatment with these drugs that you can see in the slide. However, some weeks after, the patient had a new acute ischemic event, and it was due to intra-stent restenosis. And this deleterious effect was attributed to potential drug-drug interaction between clopidogrel and cobicistat. You know that clopidogrel is a prodrug and needs to be activated through hepatic metabolism that can be inhibited by ritonavir or cobicistat, and the final result is a decrease in the antiaggregant effect and may lead to relapse of these ischemic events. In this case, the stent was replaced and clopidogrel was switched to prasugrel. Prasugrel, you know, that also needs to be activated through CYP3A4, and that although it can be inhibited by cobicistat or ritonavir, the magnitude of this interaction, and especially the effect in the antiaggregant effect, is milder and is not a relevant interaction, so this can be safely co-administered. So take-home messages of these clinical cases that this potentially fatal interaction could have been avoided if first the ID specialist had changed the antiretroviral treatment to other regimens with less risk for drug-drug interactions, avoiding the use of boosters, especially when we are separating clinical visits and more because of well control of HIV infection. And so the possibility of events within visits may be possible. And I recommend proactive instead of reactive changes in the antiretroviral regimen. Also, this fatal interaction could have been avoided if there had been communication between healthcare providers during patient management. So moving on to the next clinical case, in this case, it was a 50-year-old male diagnosed with HIV in 1995. He had received different regimens, and in 2013, he was being treated with atazanavir, ritonavir plus FTC and TDF. And at that time, he was diagnosed with a Burkitt lymphoma with bone marrow involvement. So it was an aggressive lymphoma, and a proposed treatment was the Burkitt protocol. For those not very familiar with these treatments, Burkitt includes 6 cycles of chemotherapy with all these drugs, many of them with potential serious toxicities for patients. So this case was diagnosed within a multidisciplinary group for people living with HIV and cancer in our hospital. The group is composed of oncologists, hematologists, and HIV specialists. And main direction is to maintain or start antiretroviral treatment, to do a deep review of prior history, including prior toxicities, failures, the development of drug resistance mutations, etc., and check for drug-drug interactions, and with all this information to agree in a therapeutic plan between in the group. So in this case, we check for DDIs, and we found out that atazanavir, ritonavir could cause different relevant drug interactions, increasing toxicity of many of the drugs included in this Burkitt protocol. So with prior information, we decided that the patient could be safely treated with raltegravir plus FTC and TDF. And 5 years later, the patient is in complete response of his lymphoma. Viral load is below 50 and CD4 count is around 500. So what can we take from this clinical case? First, that people living with HIV and cancer are especially at high risk of relevant DDIs, that antiretroviral treatment should be initiated or maintained in these patients, that the use of booster can be associated with worse outcomes, with more toxicity and shorter survival in these patients. And these patients may benefit of multidisciplinary approach, especially if they are taking boosters before chemotherapy. This is shown in this study, including more than 300 HIV patients diagnosed with lymphoma. And you can see that overall survival was shorter in those patients not treated for HIV in comparison with those patients on antiretroviral treatment. So first message is that these patients need to maintain or initiate antiretroviral treatment. And secondly, that patients on HIV treatment may benefit of unboosted regimens. You can see that PI-based regimens, boosted PIs, are also associated with worse overall survival. In our hospital, we have reviewed our cases of HIV-related lymphoma within the past 15 years, and we saw a trend to better progression-free and overall survival in those patients who were managed within this multidisciplinary group in green, compared with those patients in whom chemotherapy was just prescribed without consulting the ID specialist in blue. And these differences were more evident in patients who were receiving boosted antiretroviral regimens. Moving on to our last example, this was a 56-year-old male diagnosed with HIV in 1991. He received different antiretroviral regimens, and in 2010, the estimated glomerular filtration rate decreased to 40 milliliters per minute. The patient underwent a kidney biopsy, and he was diagnosed with focal segmental glomerulosclerosis. Initially, the management was conservative, but in 2019, the eGFR went down to 12 milliliters per minute, and he was proposed for kidney transplant. Just to point out the relevance of DDIs in these patients, rejection and graft loss rates in solid organ transplant are 2 to 4 higher among people living with HIV compared with general population. And drug interactions may account of part of this excess in graft loss rates. So in this case, the nephrology department consulted with us, and we agree in changing treatment from darunavir, cobicistat plus dolutegravir and rilpivirine to raltegravir and rilpivirine. The patient underwent kidney transplant with immunosuppressive regimen that included prednisone, tacrolimus, and mycophenolate. Tacrolimus levels were within the expected range, and there was no graft loss. And 3 years after, the patient is doing fine. Viral load is undetectable, CD4 around 300, and eGFR is 50 milliliters per minute. The antiretroviral treatment was later modified, and rilpivirine was switched to doravirine in order to avoid interactions between omeprazole and rilpivirine. So in conclusion, the paradigm of current HIV patients has changed, and the model for providing optimal health care and management of potential DDIs needs to evolve. For proper management, besides generating a corpus of evidence on DDIs, we have very nice databases such as the Liverpool website and others. It is crucial to guarantee fluid communication among different healthcare providers, and these patients may benefit of multidisciplinary management. And thank you for your attention, and I will be happy to take your questions.